15 years ago, at my first job in emergency, despite 2-day extensive clinical orientation, I struggled to assess and manage patients, even under supervision. In the last few years, I have seen some IMGs given poor performance reviews, repeating terms, and not being able to find an onward job. Yes, IMGs do face significant challenges, both in terms of getting into the job and then even maintaining the job due to poor performance. And in my understanding, the top 3 reasons for this are unable to meet the expectation, lack of experience, and poor communication. There's an expectation from senior medical and nursing team that all doctors are able to have a safe management plans for all patients. Now, what does this mean? It means to be able to take history, assess and examine the patients, and investigate them properly and provide initial management under supervision of your supervising consultant. And that includes teamwork and collaboration. Now, there's a different expectation from an IMG. They think that once they've got the job, they will be able to learn and meet this expectation at job, despite having significant clinical career gaps or having never worked in Western hospital system. Number 2, lack of experience. Now, there's no replacement of good clinical experience. That's why I often emphasize the need of working at least 24 months after MBBS in acute specialties before even considering a move to Australia, UK, or US. And lastly, and the most importantly, communication. When I started to look for jobs in the UK and even in Australia, I thought good communication is all about to be able to speak fluent English. And that's a common misconception. So what is the real communication then? Well, to me, the real communication is to be able to talk to your medical colleagues, nursing colleagues, and all the allied health staff to be able to understand your patients. What problems are they coming from and how can you help them? And put that all into a clinical context. So that is the basic requirement for your job. Now that's why we have devised this 6-week clinical orientation course, which is really important as it's based on practical knowledge required for all IMGs, both looking for jobs and about to start a new job here in Australia. Now please allow me to give you some basic examples of basic cases and what is an expectation and how experience and communication can really help and make that real difference. So here we're going to go very quickly through some of the very common cases, the kind of cases that you're expected to see, assess, and manage on the floor when you're working in the hospital setting. So case number 1 involves an 82-year-old lady by the name of Tracy Smith, who's been brought to the hospital after having a fall. She's using a walking stick and says that she's possibly tripped on the edge of the carpet, so a mechanical fall. She has some injuries to her face, a forearm, and the right leg. Her vitals are stable with a blood pressure 130/90, heart rate a little bit tachycardic though at 100 per minute, oxygen saturation 98% on room air, and she's afebrile, meaning she hasn't got any temperature. Now, obviously, the tasks for the junior medical officers who are working on the floor are to take history, examine the patient, and plan the initial investigation. And that's why I've put in the orientation workshop the task exactly as you think. Now, I always say to all the JMOs, whenever you're going and seeing the patient, please firstly read the triage information, read the initial information, and think what might be wrong with the patient. Now, this is an elderly lady who's had a fall. It sounds that she's tripped over, so could be a mechanical fall. But you have to still investigate on the lines of whether there could be some other medical reasons for the call. So a quick screening questions for the medical reasons of the fall, like chest pain, headache, shortness of breath, or any sort of palpitations or feeling dizzy prior to having a fall. The other thing is, if she's had a mechanical fall, where did she land? How did she land? Is it consistent with the injuries, like having the injuries to the face, forearm, and right leg? The mechanism and the impact, does it make sense? Now, focus history is very important. Meaning when you're evaluating a patient, you are asking key question. You're not asking everything and anything. You haven't got that luxury of time. So remember when you were doing the AMC clinical, you had to do it under 7 minutes. Yes, you've got more than 7 minutes here, but if you spend more time here, the experience will dilute. So you need to ask key question, key examination findings, and then come up with 1 working diagnosis and 4 differential diagnoses. Now, this is very important because when you go and discuss the patient with your consultant or senior registrar, you need to plan for the 5 key investigations that you would do or key investigations that you do and justify them. So let's look more into it, because all of these assessment, history, examination, investigation, what are they getting you to do? They're getting you to come up with a management and disposition plan, meaning if the patient is going to require an admission or if the patient is going to go home. All right, so let's take it further. And obviously, if the patient requires an admission, whether they would require a handover and follow up if they are getting discharged. So working on, so this is the schema that I've got: history, past medical history, drug history, allergy, social history, and all the various assessment tools for the syncope. So first, our key goals are to decide whether it's a mechanical or non-mechanical fall. What were the pre-fall symptoms and post-fall injuries, as we were discussing? Has she had many falls? Has she had many reasons to have a falls, like infective triggers or palpitations or coronary syndromes or strokes or CVA leading to a chronic balance issues? The other thing is that what could be the contributing factors like infection, poor mobility, dementia, unable or not being able to remember to use even the walking stick, and medication, which might be causing some postural syncope. Uh, what's the social situation like? Now, this is very important, especially for the patients who are actually going to get discharged from hospital back to home. And we need to know that if they're well cared for by a family member or if they got services at home, so that they can be safely discharged at home. As I said, it's all about the safety. Moving on, what would be the key examination findings? Always start with the vitals: postural blood pressure and postural heart rate. This is an elderly patient who's come in with a fall. Could this fall be a medical or organic medical reason to this fall, like an acute coronary syndromes, a CVA, or postural hypotension in terms of being over medicated with antihypertensives? So all of these things are very relevant, and that's what is showing with this value of vitals and postural blood pressure and heart rate. We need to also do a neurologic examination looking for any grossly abnormal cerebellar signs and focal deficit. We need to pay special attention to the cardiovascular examinations. In this age group, the cardiovascular examination that would be relevant would be a murmur. That's right, aortic stenosis murmur. So these aortic valves get calcified, which would give patients exertional syncope, exertional chest pain, or exertional lightheadedness and dizziness. And that's what I've said, murmurs, especially aortic stenosis. What about the chest symptoms? Some of the most common infections are chest and UTI. So exclusion of chest symptoms and UTI symptoms. And obviously, I always tell all my GMOs to stand the patient up, see if they can mobilize. But if the injuries are very gross and very deformed, then obviously you need to get an X-ray done. So these are the key examination finding tools. Now let's see, the patient has come in. She has got some bruising on the right side of her temple, as you can see in this picture. She's also got some bruising on the right side of her wrist, and she's also got some knee bruising. So we're going to focus our examination on these areas plus all the areas which are injured. Moving on. So what would be the working diagnosis? It could still be a simple mechanical trip and fall. As she said, that she was the person who was walking towards something and she tripped over the carpet. It could be something which has led to the right knee injury, and it could be related to something related to cardiology problems or neurology problems, like she might be having syncopes, she might be having CVAs, she might be having, as I said, the aortic stenosis can cause exertional symptoms and even syncope. All right, moving on. The other infective triggers, as we discussed, could be UTI or lower respiratory tract infection. And we've also got to be cognizant of the fact there could be something else going on, like neglect, abuse, or trauma. So how would we investigate that? Well, I often say, whenever you think about the investigations, please plan investigation in your mind as bedside, laboratory, radiology, and any special tests. So in terms of bedside investigation, obviously doing ECG and venous blood gases, what are we looking for? Any arrhythmias, any grossly abnormal metabolic abnormalities like any respiratory acidosis, metabolic acidosis, which might be consistent with infection or sepsis, any drop in hemoglobin. You can still get that information on a VBG, which might be consistent with the trauma somewhere else where the blood is slowly accumulating. Laboratory, obviously, you need to know full blood count, electrolyte, and troponin. Now, even though the fall sounds like it could be purely mechanical, but in elderly patients, you've got to make sure that these basic tests are still done before you even make a decision in consultation with your specialist that this patient can go home or whether it needs to be admitted. So that's all very important and very relevant test. And these are the things which often the JMO struggle with. They would not know what test to request, how would to request these tests, and how to input that test in the clinical context of a fall. Now, imaging is very important. This patient has got bruising. There might be an information about loss of consciousness. She may have had a long lie. She may have had a stroke in that age group. So CT brain is very important, especially if there's any focal neurologic deficit or any period of confusion compromising the overall GCS score of 15 or any other issues that you're concerned about. Like if it's a recurrent fall, you should always be thinking about subdural hematoma. From the infection point of view, you need to get the chest x-ray. And obviously for this specific patient, you need to also get the x-ray of the right forearm and the right knee. And special test, as I said, the infective exclusions are important. So we'll do a special test like urine dipstick or urine analysis and urine cultures if they look that there is a suggestion of infection there. Moving on. So these are the investigations, the bedside investigation and the CT scan and the X-ray of the knee, the CT, the ECG, first of all. Now, in terms of interpreting the ECG, I always say that, look, you need to be able to comment on the rhythm, any underlying arrhythmia that is, or any gross ischemia or anything which is looking abnormal from the heart block or tachyarrhythmia point of view. So in this particular ECG, it looks like it is a sinus rhythm, meaning every P is followed by QRS-P, QRS-P, QRS complex. So it's a sinus rhythm at a reasonable rate between 70 and 80 beats per minute. Now, looking for any ischemia, there does not seem to be any gross ST elevation or any gross ST depression in any of the territorial coronary artery areas. So it does not look like that there's any suggestion of any ischemia on this ECG. Obviously, we need to compare the ECG with the previous ECG. And luckily, in this current environmental system, all of the previous ECGs are already uploaded onto the electronic medical record. The CT brain, and obviously we go through the detailed assessment of CT brain, but mainly what you're looking for, if the patient has got a right-sided head injury, I often get you to start from the right side. Is there any scalp swelling or hematoma? Is there any fracture of the skull here, which is that whitish bone or hyperdense area, which is shown on the axial view of the CT scan? Plus, looking at the brain in these small crevices, is there any evidence of subdural? As I said, that the patients, elderly patients in particular, who've got poor balance, they could have acute and chronic subdural. Or is there any parenchymal areas which show any infarction or any bleeding, any associated midline shift? Doesn't look like that there's any of that happening in here. And lastly, because the patient had bruising on the knee, if you remember, over here, we'll look at the knee x-ray, and this x-ray we're looking again from the point of view of any fracture along the distal femur, any fracture involving the patella, any fracture involving the tibia and fibula in the area where the pain is. So it looks like the patient has got a normal investigation in terms of ECG, CT brain, and x-ray of her right knee. So the laboratory investigations have come back. Hemoglobin is 134, white cell count is 6, platelets 340, sodium 132, potassium is normal, creatinine is borderline up, but it's okay, and troponin is also normal. So this is a very practical case. That's why I've put and kept it that way. Most of the patients who come in after having a fall would not have any gross abnormalities. And you need to put your investigative cap on, thinking, what can you help this patient with? Is this a pain management after the fall because of this superficial musculoskeletal injury or muscular injury in that particular case? Or is there something more to it in terms of history which we might be missing or overlooking, like any other cardiogenic or neurogenic syncope which might be leading to a fall? Doesn't look like it from our screening tools so far. So what else? We've done the imaging, we've done the urine analysis, which is normal. Moving on. So I thought that I'll briefly talk about some of the syncope rules, which are the tools which help us establish the clinically relevant risk for this patient. If this patient was to go home, how would the outcome be for this elderly lady who's in her 80s? So any predisposition to vasovagal symptom, that is based on the fact that if she's got hypotension, if she got postural hypotension or tachycardia, if she's on medication, then that scores a point of -1. Any history of heart disease scores a point of 1. Any systolic blood pressure of less than 90 or more than 180 scores a point of 2. Elevated troponin, 2. Abnormal QRS excess, while our QRSs were normal. So QRS duration, that means that there's an underlying bundle branch block. Well, our QRS axis and duration were normal. Corrected QT interval, our patient had a normal corrected QT interval. And vasovagal syncope is more likely, meaning that if the patient says that her symptoms are more pronounced when she's standing up, then obviously it would suggest a vasovagal syncope or cardiac syncope. The patient said that, look, I had chest pain and severe shortness of breath followed by palpitation. That is scores 2. So you can use these score and plot it up and come up with the overall total score, which if it's above 29 all the way up to 83, it is very high risk of any clinical deterioration, estimated risk of serious adverse events. But as I said, our patient sounds like she had a mechanical fall from the uneven surface and then she's had injury. So it looks like it's more mechanical fall, and she does not qualify for any of these risk factors as I understand it. So overall, her risk would be extremely low, medium to low. So I think her estimated risk of serious adverse event is very less likely. So this is the information that you must know before discussing the case, and it will look good when you go and talk to your consultant that, look, I've done Canadian syncope rolls. Based on my assessment of this elderly patient, she's had a simple mechanical fall. There's no red flags of, cardiogenic and neurogenic syncope. I've done the basic workup in terms of ECG, blood, CT brain, and X-ray, and they all appear to be normal. I've also given the patient inhalation analgesia, and she seems to be looking okay. And based on this assessment tool, it looks like the patient is low to medium risk. So overall, I think the patient, if there are no social issues, can be managed at home. So be open about your diagnosis, about your workup, about your planning, how you're going to manage this patient. And this is something which we expect from all JMOs, not just you. And if you need any help in terms of making you come to that realization, that's fine. But this is bread and butter case, and you'll be doing this repeatedly. And once you've seen a couple of these cases and you've worked them up in this way, it will become very easy for you. So that comes from experience and also comes from an understanding around that case. So management disposition, obviously we need to make sure that she's well analgesic. We would get the patient assessed by the ASSET team or aged care assessment team. We would also make sure that patient, if she's going home, then we talk to the relative and make sure they're happy. They may have some further insight. The patient's had many falls. She lives by herself, and we're not happy that she goes home overnight. She can't be kept in the hospital overnight and can be discharged in the morning. We can actually come and pick her up. So these are the areas which are obviously very important. And follow-up. Like, the aged care services can do a phone follow-up. There's some other services across various hospitals who can also do in-person follow-up. So this is very important to all practice that and put that into motion. So remember, the patient, as I said initially, there's an expectation. So expectation from this patient that this patient is safely assessed and managed. And if you're thinking that this patient can be managed out in the community, so I never say to my patients that I am going to discharge you. When they come to emergency department and I'm thinking of discharging them, I never say that I'm discharging you. I say that I'm going to manage you as an outpatient in teamwork and consultation with your GP. And I'll give you some, letter that you can go and follow up with the GP. And this letter would have specific instructions in what to look out for and how to investigate and manage this further. And I think this is one of the crucial areas of safe medical management. You always say to the patient that, look, this is something which is relatively low risk. You don't require to come into the hospital, and we can manage you as an outpatient. Okay. So that's why they need follow-up in 48 hours. And there are a few hospitals in which their elderly falls clinic. Obviously, this is their first fall. Sounds mechanical, but this might be a good opportunity to refer to one of the clinics. And these clinics are multi-disciplinary. So if there's an uneven surface at home, there could be an occupational therapy who can go and assess the home environment, whether it's safe for this, alone living elderly patient. All right. So moving on, we've got case number 2. 7-month-old Ryan has been brought to a small regional hospital by his mother, Emma, who's very concerned about Ryan's breathing. He has been unwell with cough and runny nose for 2 days. His coughing is worse today, and he seems to be having noisy breathing. Ryan's also off his food for past 24 hours, and COVID rapid antigen testing is negative. His heart rate is 130, respirates 54, so a little bit tachypneic, and saturation of 90% on room air, so hypoxic. And he's got a temperature of 38.1. Now, obviously, this Ryan looks very happy, but this is not the actual patient. The actual patient would look quite sick. Now, tasks, as I always said, are to take focus history and examination, plan appropriate investigation, management, disposition. Now, whenever I get junior doctors to go and assess the patient, some of the junior doctors, and especially IMGs, would be reluctant and going, oh, I've never worked in pediatrics, so I feel reluctant to go and ask all these information. It does not really matter if you've not worked in pediatrics. What matters is that you're going to learn about these practical pediatrics. You may never practice pediatrics ever in your life. And this is a very opportunity to go and do that now. You cannot keep on dodging certain cases or certain pathologies and be expected to come out as, a winner at the end, having a good overall assessment. So if the patient or a case makes you uncomfortable, make sure that you go and spend as much as time is required to have a comfortable assessment and disposition planning for these kind of patients. So even before you go into the cubicle and see this patient, you should always be thinking what could be wrong with this patient. So few of the differential could be, look, he's tachypneic, he's febrile, could it be an infection, something as simple as pneumonia? All right. Could it be bronchiolitis, which is a very common occurrence in this age group, and he seems to be an unwell child with history of some early symptoms with cough and runny nose for 2 days, and now it looks like he might be day 3 bronch. He's also febrile. So our history and examination should be focused on these principal diagnoses: upper respiratory tract infection, lower respiratory tract infection, bronchiolitis. And this child is 7 months. It's very unlikely that he would have asthma in this age group. Moving on. Patient evaluation, again, the same priorities: key question, key exam findings, 1 differential diagnosis, 1 main diagnosis, and 4 key differential diagnosis, and key investigation and justification. You need to manage him and decide whether this patient needs to be admitted or follow up. And then finally, if he needs an admission, we need to hand them over to the pediatric registrar or a consultant for an admission. All right, moving on. So key question, in pediatric, it's very important to get the chronology of history. What was the first thing which was happening? Was it the runny nose? Was it the cough? How did it evolve from runny nose to cough? What were the features along with that? Was he febrile? Was he spiking temperature? Was he looking flat or lethargic? Okay, moving on. What happened the following day? Did he have any vomiting and diarrhea? Did he come off his food on day 2? And these things are very important because they paint an overall picture of severity of infection. So use symptoms chronology. Symptom severity, like any of the red flags, especially from the bronchiolitis point of view, if the child has had apneic smells, if the child has had cyanotic spells, these are very important for us to know. And as I said, the pediatrics, any pathology, we must always check intake, because kids, when they're sick, the first thing that they go off is liquids and solids, and that tends to reduce the urine output. So that's a very good way of assessing the severity of their illness as well, in terms of their intake and output. And then they lose weight, which is actually a very good way of assessing their dehydration. Now, if there are any other risk factors, prematurity, some of the premature childs have got immature lungs, and they are more likely to have an adversity, even if they've got bronchiolitis or chest infection. So these patients tend to get admitted more frequently even for an observation. And obviously, if the child is unvaccinated or non-immunized, then they're more likely to have a serious bacterial infection risks. And we need to check up on the sick contacts, because some of the kids who spend time with some adults who've been unwell, or spend time with other kids who go to childcare, then they catch the infection, the bugs and the viruses more frequently. All right. So in terms of examination, when you're thinking about any respiratory distress, you get the vitals, especially from the hypoxia and respiratory rate and the work of breathing point of view. You do the ENT exam because that's where the focal infection might be. The child may have, inflamed pharynx. They may have some ENT findings of ear findings of inflammation, and appearance overall. If they're flat, if they're active, if they're motile, if they're cyanotic, if they cap refill time, which might be an inadequate indication of their um, hydration status is poor or good, and then listening to their chest for any murmurs, because even though we're thinking it could be bronchiolitis or respiratory tract infection, it could be the first sign or first presentation which is exacerbated by bronchiolitis in terms of having congenital cyanotic heart disease menacing. It's unlikely to present that late, but then again, that could be a possibility. And you need to examine for murmurs, hepatomegaly, make sure that bilateral femoral pulses are there. Moving on, chest, looking and listening for any signs of work of breathing, any tracheal tugging, intercostal and subcostal recession, any sort of focal dense consolidative sounding, which with reduced air entry. All of this makes sense and are very relevant for this patient. Now, your working diagnosis day 2 bronchiolitis. Obviously, the first differential is viral lower tract infection, or it could be pneumonia, or it could be cardiac failure, although very unlikely. And it could still be foreign body inhalation, again, a very unlikely, but you've got good differential sets. So this is the x-ray that you've done because the child was quite hypoxic and work of breathing was quite significant. So in terms of commenting on the x-ray, there could be several systems of commenting the x-ray. One of the most common reasons, a common system that I follow, if there's anything abnormal, I'll just go right for the money. But if there's nothing abnormal, I'll start off with the trachea. I say trachea is midline. There's no mediastinal widening. Looking at the heart shadow, the heart shadow does not look enlarged, meaning that there's no underlying cardiomegaly, which would suggest any congenital heart disease. The lung on the right side does not show any collapse or consolidation on the right upper, mid, and lower zones. The cardiopharyngic and the costopharyngeal angles are clear on the right side. And similarly, the lung on the left side on the upper, mid, and lower zone looks clear. There is no evidence of any consolidation or collapse, and the cardiopharyngic and costopharyngeal angle looks normal. So overall, my impression is this is a normal chest X-ray. Now, bedside, obviously, the test that you do is cardiac and saturation monitoring. Laboratory, now pediatrics are perhaps one of those good patients where you don't have to do many laboratory tests, a blood test or cannulation. Most of the patients in pediatrics, even in terms of rehydration, can be managed with oral or NG tube rehydration. Only in very severe and reserved cases you would consider IV fluid therapy. We've done the X-ray and we've gone through it. Any special tests, and what special tests might be relevant for this particular patient? Well, there could be tests related to nasopharyngeal swab, COVID swab. There could be tests related to any other signs of infection. Signs of infection might be UTI, even though it does not look like it, but it's always good to do basic septic workup. All right. So moving on, nasopharyngeal aspirate, you'll do a urine dipstick, and this is the admission criteria of bronchiolitis. Now you're thinking this child has got day 2 bronchiolitis. We know for a fact that child or children tend to get worse on day 3, day 2, day 3. His respiratory rate more than 60 or less than 80. His 54, evidence of increased work of breathing. Let's just say that he has got intercostal, subcostal recession along with the tracheal tugging. His oxygen saturation R90. So that means that he's actually trying to compensate for his hypoxia with his tachypnea. So he would need oxygen therapy. Sorry, moving forward again. And his feedings are not getting tolerated. So he's not really eating or drinking and he's getting further dehydrated and flat. And the parents might be very concerned. They might be first-time parents. They might be parents with genuine concern that he's not looking well. And he's got high-risk features in terms of prematurity. He has had, chronic heart and lung condition. He's got certain level of immunodeficiency. All of these factors are requiring a mandated admission for bronchiolitis. So in terms of my management, obviously we need to give him some Panadol for temperature, oxygen for hypoxia, and consider giving oral feeds. Obviously, if he's breastfed, the breastfed is often best thing, or NG feed if he's looking too unwell or lethargic, or IV hydration if it's looking completely flat, as I said. Specific management, obviously all that mucus secretion is sitting on the back of the nose. So what we need to do is do nasal suctioning to try extract all that material out. We also need to consider doing, if the patient is brought into like a more peripheral hospital, then we need to consider thinking about a pediatric hospital, a pediatric facility. And, referral meaning referring it to the pediatric registrar in the accepting hospital and communicate the plan about the parents. So whenever you do a referral about any patient, follow a method of ISBAR, which is introduction. Tell them about what you've got at hand, what is the relevant background, what are your positive examination or assessment findings, and what do you want from the team. So follow always ISBAR method. My name is Dr. Rizwan Qureshi. I'm calling from so-and-so hospital. I've got a 7-monther child who I think has got day 2 bronchiolitis. He's got a previous background of having some prematurity, let's say. He was born at 35 weeks and was kept in special care nursery and had some breathing issues and required a bit of oxygen. So obviously there's one subtle risk factors there. In terms of my assessment, he's got moderate worker breathing with tracheal tightening and intercostal recession. Is requiring oxygen with a saturation of 90%. So in my recommendation, the child needs to be admitted. We'll do some suctioning to clear some mucus secretion. He will still require an ongoing oxygen support. Plus, he would need rehydration. We're trialing NG tube rehydration at this stage, see if he tolerates. If not, then he would eventually need an IV therapy, but doesn't appear to be the case right now. Have you got any questions for me? So this is how you need to refer the patient to any specialty. Make it brief, stick to the positive findings, and come up with the final recommendation which you think the patient requires an admission for. So these are very bread and butter cases which are important, and you need to be aware of these cases. These are the cases which you will see frequently. These are the cases that you will get marked and judged. I should not use the word judge, but yes, you will get judged on these cases. And these are important. And you need to practice them. And I can understand that, look, we as IMGs have got, sometimes coming onto the different country, we've got large career gaps. We may have had significant amount of lack of experience back in our own country. But then again, utilize the opportunity of having discussed these cases. What are the practical aspects of taking history, doing examination findings, how to refer these cases? It's all about proactively talking about these cases before you start the job, before you even start the application process, because this is a medical linguistic, medical terminology. It needs to be a part of your persona, so that you're able to convince the doctors and convince the medical recruitment agencies that you have got that validated experience that makes you in par with local graduates. I hope you like this conversation and some of the relevant cases to just to give you a little bit of taste of what is in store for you. There is good amount of information in these cases to give you an understanding that this is a basic assessment and how can we. So basically what I'll say at the end, that look, please join our clinical orientation course, especially if you think that you've got a large career gap, you haven't practiced in a Western country. We will go through 50 of the most common clinical cases, and we'll go through exactly as we have done here in terms of what are the key questions to ask in terms of history, how to examine these patients, what are the basic tests that we do, and how to manage these patients and refer them on if they require a hospital admission, and how to even safely discharge them back home if they need. This will then give you confidence. This will then give you that extra layer of safety. Try and meet that expectation. Your obviously communication would be much better because you'll be speaking and talking in that medical terminology which is relevant to Australian health system. And this is almost related to your experience level. You're trying to improve your understanding of local health system by having that experience matched to the experience uh, which is relevant at the junior medical officer level. Thank you very much. Look after yourself. I'll see you at the course.